everyone. My name is Anna Radakrishnan. I'm a first-year cardiology fellow at the Mount Sinai Hospital in New York City, and I am a CardioNerds Academy graduate. Today, we will be discussing groundbreaking new data from the ATTR-CM trial, examining the efficacy of acoramidis across different genotypes of transthyretin cardiac amyloidosis. This includes very exciting findings in patients with variant disease, in particular those carrying the V142L variant. This data was just published in JAMA Cardiology and presented at the AHA annual meeting.
Hi, everybody. My name is Georgia Vasilakis Tsatiris. I'm a current chief resident at the University of Pittsburgh, UPMC, and a current faculty member of the CardioNerds Academy this year. Today, we're exploring critical questions about whether acoramidis works equally well in patients with wild-type versus variant ATTR cardiomyopathy and what this means for our patients, particularly those with Western African ancestry who carry the VAL142I variant. We once again have the privilege of speaking with Dr. Kevin Alexander, Assistant Professor of Cardiovascular Medicine at Stanford University School of Medicine and first author of this important study. Dr. Alexander, welcome back.
Yeah, thanks for having me.
So to dive into it, Dr. Alexander, we've discussed the ATTRibute-CM trial before, which showed the overall benefit of acoramidis and ATTR-CM, but this new analysis takes a different lens. Can you tell us what specifically this study aims, why it was important to look separately at wild-type versus variant ATTR-CM populations, and what key differences exist between those two forms of the disease, particularly regarding the V142L variant?
Yeah, so we know from the ATTRibute-CM study that acoramidis is effective at reducing cardiovascular hospitalizations, mortality, and reducing declines in 6-minute walk and KCCQ. And so as we look further into that trial, it's important to look to see subgroups of ATTR-CM patients because we know that there's different degrees of morbidity and mortality depending on the subgroups. And one important distinction is the genotype. So wild type ATTR versus hereditary or variant ATTR, those two subgroups can have distinct natural histories. Variant ATTR patients tend to have a more aggressive disease course. They're more likely to have not only cardiomyopathy, but potentially some degree of neuropathy. So it's important, I think, to see what outcomes look like in this population, particularly when we use a disease-modifying therapy like acoramidis. So that's kind of the main intent of this current analysis is to see that the treatment effect that we saw in the overall population, how does that translate into specifically a variant ATTR-CM population?
Awesome. Now let's dive in a little more to the core findings. Can you share with us the mortality and cardiovascular hospitalization data in the wild type versus variant ATTR cardiomyopathy patients treated with acoramidis? And let's hone in on the V142I subgroup specifically. Can you walk us through those findings, including what happened to the placebo group?
Yeah, so in the 30-month trial, at the 30-month endpoint in the trial, we saw that there is a benefit for acoramidis and for the endpoint of all-cause mortality or first cardiovascular hospitalization for both the wild type and variant ATTR groups. For wild type, we saw a reduction of 31%. In the variant ATTR-CM group, a reduction of 59%. When we looked at the extension data that went out to 42 months, we saw a similar benefit across both subtypes for all-cause mortality, with a reduction of 30% for the wild-type group and 59% for the variant group. Specifically for the V142I variant, we saw consistent reductions in those endpoints, similar to the overall variant ATTR population. So I think the takeaway is that there was consistent treatment effect across wild-type to variant ATTR-CM, as well as specifically the V142I variant compared to the other groups.